Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. After skin cancer, prostate cancer is the most common cancer among men. The good news is that it can often be treated successfully. A movement called Movember, which combines a mustache and November, asks men to grow a mustache and raise awareness for men's health topics, including prostate cancer. Joining us today to discuss this is Mayo Clinic urologist, Dr. Raymond Pak. Thanks for joining us today, Dr. Pak.
Thank you, Sanjeev, for the invitation to be here today.
So Dr. Pak, just in terms of prostate cancer, can you tell us who's at risk for developing this?
In the United States, about 1 in 9 men in their lifetime can develop prostate cancer. And certainly around the age group of men in their 60s is the most typical age for men to be diagnosed with prostate cancer.
So we've just heard about the screening for colorectal cancer, for example, in decreasing the age for when men should be screened. What about prostate cancer?
That age-specific recommendation for screening has changed over the years. Currently, the American Urologic Association supports screening for men at average risk between the ages of 55 and 69. And then prior to 55, it should really be a shared decision and discussion based on risk factors. So what are those risk factors? So men with a family history of prostate cancer. A significant family history would be a first-degree relative, such as a father or brother with prostate cancer, or a more distant relative, but at least 2 affected distant relatives with prostate cancer. And then any other strong family history of hereditary colon, breast cancers, as well as prostate, of course, should be considered in a younger age group. So between 40 and 55 is that high-risk group that we need to kind of screen for if there's a strong family history or race. African-American men should also be considered to be screened earlier, under 55.
And so in terms of screening then, how do you do that? If you determine that somebody should be tested for this, is this an invasive test? What do you do?
And oftentimes prostate cancer has no symptoms. By the time men develop symptoms of prostate cancer, it's usually at an advanced stage. So symptoms such as blood in the urine, painful urination, inability to urinate, or pain in the hips and spine, those can all be very advanced presentations of prostate cancer. So that's exactly the reason why we screen men actively in the specific age groups, because there are no symptoms whatsoever. So to answer your question, to how do we screen men, it includes a combination of a prostate exam, usually done at the time of a physical, and it's usually done with a digital finger through the rectum. And so that could be done by a family practitioner, a primary care physician, and of course, urologist. That's a lot what we do on physical exams in the office. And then, of course, the blood tests, the PSA blood test, which is the prostate-specific antigen test. And this test has been widely available for many years. And this blood test has significantly contributed to the detection of prostate cancer, but also successful early identification of men with cancer.
Obviously, with Movember, we want to sort of decrease any fear for men. When I'm listening to this physical examination, that sounds a little bit painful. Is it such?
Depends on your point of view, but certainly a prostate exam, it can be very painless. It's simply a finger, an index finger, usually during the physical exam. And once a year is what we recommend minimally. And so, that can be a barrier for some men. I won't lie that, some men fret coming in the office about that exam. Some men actively seek me out because I do tend to have smaller fingers. So, if there's any concern about
it's important. It's important.
So if there's any concern about discomfort from a prostate exam, you might want to look at your physician's index finger to determine if it's something you want to sign up for. Certainly if your physician is a linebacker and has a finger that's the size of someone's thumb, you might want to seek another healthcare provider. But no, all joking aside, prostate exams are very well tolerated. It's more psychological barrier than actual physical harm or pain.
So you mentioned the physical exam and the blood test, the PSA. If they're elevated or you're suspicious, how do you then move on to the next stage of diagnosis?
So if there's a level of suspicion based on the prostate exam or an abnormal PSA value for a man's age or history, then we certainly would take the next steps to determine what the underlying risk of prostate cancer is. So for many years, the standard of care was to proceed with a prostate biopsy with ultrasound guidance. And that's still, the vast majority of the way we still proceed with men today. Now, with the advent of advanced imaging technology, we do have the availability of MRI, for instance, to help give us a very detailed picture of the prostate. Now, I always remind men that MRI technology is wonderful. It does allow us to see the prostate and potentially detect visible cancer lesions in the prostate. So MRI is very important for that visible detection of a suspicious lesion. However, I always remind men that the MRI is not 100% sensitive or specific, and therefore biopsies are still recommended despite MRI findings. So if an MRI shows a lesion, we most certainly would recommend proceeding with a MR fusion biopsy, which means we're going to take the MR images and perform a very accurate biopsy of that prostate. If the MRI is negative or normal appearing, we oftentimes still proceed with a biopsy based on other risk parameters. In that situation, we then rely on the traditional transrectal ultrasound guidance imaging for those biopsies.
That's what I was going to ask you. When you talk about biopsy, which is simply taking a piece of tissue in a needle so you can analyze it in the lab, how do you physically do that?
It does require a needle core biopsy. These are small needles that will penetrate the rectal wall. If you're doing a transrectal approach, the needle will penetrate the rectal wall and enter the prostate and retrieve a sliver of prostate tissue, small enough to not be a problem, but large enough to allow us to make a diagnosis based on tissue sampling. I'm sure, as you're aware, most cancers are diagnosed with tissue sampling and you cannot rely on imaging alone. We do also offer other alternative routes of biopsy of the prostate, such as a transurethral approach during a cystoscopy. But the other more common approach that is also very popular among patients now is a transperineal approach. The transperineal approach reduces the risk of infection tremendously for men, which is one of the biggest fears of having a biopsy transrectally.
One thing I've heard about prostate cancer is if you are going to get a cancer, this is one of the ones to get in terms of it's a better cancer for treatment. Can you talk to us a little bit about that? Because some people don't have treatment, some people do, and the prognosis can be favorable if caught early.
That's absolutely correct. So prostate cancer can present in patients in a wide spectrum. Certainly, if the cancer is detected early, and hence the purpose of screening, we can usually formulate a plan. If it's detected at an early stage and it's still localized and non-aggressive appearing, we can oftentimes just survey the cancer over time. We call that active surveillance. We can follow with imaging and blood testing and exams, and men do not need treatment at all, but close monitoring. And then there are times when men have lapsed in their screening or never been screened at all due to various reasons, whether access to healthcare or fear of being seen by a urologist or a doctor in that area. So when men present without any history of screening prior, they tend to present with more advanced cancers. So in fact, historically, a few years back, the U.S. Preventative Task Force determined that prostate cancer screening was not recommended. And we actually, as urologists, saw an increase in the stage of presentation of cancer back to before the PSA test was invented. So when the PSA test was released for widespread use, we saw a downstaging a lot of cancer presentation because we were detecting cancers earlier. And then with the change in the recommendation, it confused a lot of physicians, especially primary care physicians, to the point where they stopped checking the PSA test. And that allowed some men to fall through the cracks and present with more advanced cancers. So a lot of my colleagues who treat prostate cancer have in the recent years seen men at presentation with more advanced forms of prostate cancer. In those situations, it can be very difficult, essentially get them cancer-free or make them a cancer survivor. However, prostate cancer, unlike many cancers, has it can be a long process. When you look at 5-year survivals, and that's a metric that most organizations use to determine prostate cancer aggressiveness, prostate cancer, even in some of the advanced stages, still has nearly 100% 5-year survival. And that's different than the perspective of someone having pancreatic cancer or brain cancer, where the 5-year survival's not even 15% at times. So, I do counsel patients based on that and tell them, to put things in perspective. I encourage all my patients to make long-term plans still and to have a positive outlook, because the dynamic is also, the landscape of prostate cancer treatment is also changing, and it's a dynamic process.
One of the things that you mentioned there was about the stage of diagnosis. Can you just describe to us, Dr. Pak, what do you mean by the stage?
So the stage of the cancer is the extent of the cancer within the prostate itself. So when the cancer is localized to the prostate, we usually say that's organ confined, or stage 2. When it's a stage 3 cancer, it simply means that the cancer has gone beyond the capsule or the surface of the prostate. And so that means that the tumor has actually penetrated the surface of the prostate and gone beyond its nearby structures outside of the prostate wall. Stage 4 prostate cancer means that the cancer has grown into a lymph node or has grown far away from the prostate, distant until liver, surrounding organs, lungs, bone. So that would make it a stage 4 cancer.
I see. And then obviously I'm assuming, depending on the stage, the treatments vary. Can you talk to us a little bit about the treatments that patients can expect?
When we say localized cancer, we're simply focused on cancer that has not left the prostate, has not penetrated the surface of the prostate, has not gone into the bones or lymph nodes. So for localized prostate cancer, depending on the Gleason grade, we will then determine the appropriate treatment. For men diagnosed with what we call Gleason 6 or grade group 1 or low risk to very low risk prostate cancer, we oftentimes recommend active surveillance. And active surveillance for a man should be the first line of consideration when diagnosed with this type of cancer. Of course, when the cancer is more advanced, then we certainly tailor the focus to actually treating the cancer. So any man with pardon all the lingo, but a Gleason score 7 or higher, grade group 2 or higher prostate cancer, and somebody with what I would consider intermediate risk parameters really should be encouraged to treat. Intermediate risk parameters or higher should really be encouraged to focus on treating the prostate cancer, especially if they have a life expectancy of more than 10 to 15 years. And that's an important topic to mention, is that, because prostate cancer can present at very advanced stages or ages, life expectancy is a consideration and part of the discussion. Because if a man is in his 80s and has competing medical problems, sometimes even with significant prostate cancer, we may not treat that cancer, because our goal is to do no harm.
You mentioned the Gleason grade. Just for the listeners and the viewers, can you explain a little bit what that is?
Gleason grading is a pathologic grading system that really looks at the actual cell structure of the cancer under a microscope, and they look at the cell structures to determine the aggressiveness of the cancer. So the Gleason grading system starts from 6, or 3 + 3 = 6, to 5 + 5 = 10 on the extreme advanced presentation form. So they've tried to shift away from this Gleason pattern to what they call grade groups, grade group 1 through 5. And simply for the fact that when men hear a Gleason 6 cancer, to them, they hear 6 out of 10, and they get very concerned that the cancer is beyond 5. To them, it sounds more advanced. So we've changed the nomenclature over the years to accommodate for the fact that Gleason 6 prostate cancer is actually a very slow-growing cancer and very early detected and non-aggressive.
Are there times where you think, for example, patients should seek a second opinion?
I think oftentimes when you use the basic minimum to make a diagnosis and stage a patient, I think that is all that's required for most providers. I think for patients who want more information to ensure that they are accurately staged and accurately diagnosed, I think a second opinion at a center of excellence is important, because there are various things we can offer, such as a second opinion review of the pathology slides. You'd be surprised how often pathologists will disagree, looking under a microscope, looking at the same exact cell, and tissue, and they may disagree about the grading of the cancer. So Gleason grading can be somewhat subjective, and it's based on that physician's experience and opinion. So I think, at Mayo Clinic, of course, we have very experienced pathologists who most of the day they spend looking at prostate cancer. So they really become specifically interested and also experts on prostate cancer. So they can be better qualified to make some of those calls when there is a kind of a subjective situation. The other reason why people come for second opinions to a prostate cancer specialist is also to ensure that there are no other tests that can be run that may improve the staging of the cancer. So one example of staging imaging that is really helped over the years is MRI. I'm always surprised at how patients who are diagnosed with prostate cancer oftentimes don't have an MRI to help visually stage that cancer. Now, I'm not saying that every patient who has prostate cancer needs an MRI, but I certainly feel that some patients would benefit from an MRI to ensure that the cancer was not understaged. So if a patient has not had an MRI prior to or after a biopsy, that often makes me concerned that we could be understaging the cancer. It could be a phenomenon of like hitting the tip of an iceberg. How do you know there's not more in the prostate than what that one needle picked up, or that those two needles picked up? So I think accurate staging of the cancer will really help determine and help patients make a better decision about their future treatment plans or active surveillance plans.
And I think we're blessed here at Mayo Clinic to have experts like yourself, but also, as you said, the pathologist to really hone in on the diagnosis. As you see, many patients can be, as you said, underdiagnosed, and that is very helpful information. With the coronavirus pandemic ongoing, have you seen any changes in terms of treatments, for example, for patients, or how patients are presenting to you?
We've been fortunate at Mayo to have a very robust testing for the virus, and we use that testing in our everyday practice to protect patients, but also to protect care providers so that we can continue to do what we do. And I think what we've seen, especially during the height of the pandemic in the United States, is that a lot of patients weren't able to get access to care for their prostate cancers, whether it would be for diagnosis for an elevated PSA and the concern looming of a potential cancer diagnosis, or somebody who has confirmed cancer that wants that prostate treated and their local providers haven't been able to reopen in a normal fashion. So we've been fortunate that we've been able to continue to offer the full breadth of prostate cancer related treatments or diagnoses to allow the continuity of care, but also expediting care for patients who really need to be treated in a timely fashion.
One of the things that we are aware of is about healthcare disparity. And I think earlier on you mentioned certain groups are at higher risk of prostate cancer. What are we doing to get that message out to them about screening and the diagnosis and what the actual condition is?
That's a great question. And they've looked at socioeconomic factors that help or prevent the diagnosis of prostate cancer. And I think that's why, awareness campaigns like Movember are important to get that message out to men. As men, we're very reluctant to seek care on our own. Oftentimes, we have to rely on a spouse or a family member to really bring that person in to get screened or checked. Even children of men also can sometimes be advocates. But there are men out there that want to be healthy but aren't aware that there's access. Most cities, most areas do have what we would consider yearly free campaigns or programs to offer prostate cancer screening. The American Cancer Society, and they will have campaigns for prostate cancer screening. Of course, Movember is a big national movement to raise awareness. But if you look around the course of the year and within the country, there are a lot of resources that men who have limited access to healthcare where they can actually get free screening, whether that's a combination of the prostate exam with a PSA or with a PSA alone or a prostate exam.
Any new changes in treatments for prostate cancer? We touched upon it a little bit. Anything in the horizon that's coming up or new that we're doing today?
One of the reasons why I decided to focus on prostate cancer is there is a tremendous amount of innovation around how we treat prostate cancer, whether it's surgically, whether it's using energy to ablate the prostate, or even some drug therapy. So it's a very exciting subfield in urology. I can simply start with the surgical treatment of prostate cancer. Since I started as a urologist, we used to do open surgery commonly. And then now the standard of care has really become minimally invasive laparoscopic surgery with robotic assistance. And for me, my bread and butter procedure that I perform all the time at Mayo Clinic is robotic assisted laparoscopic prostatectomy. And with that technology, it's fascinating. You know, when I turn on the robot and operate, I feel like I'm in a science fiction movie, because it really is an amazing piece of technology that has allowed us to perform very complicated surgeries, but in a minimally invasive fashion that allows our patients to suffer less with less pain, smaller incisions. The recovery period is remarkably quick. We can really get effective treatment of the cancer and also effective preservation of male function. You know, one of the biggest fears of having surgery is a man may potentially lose sexual function and lose the ability to control urine. Some of the tools that we have available to us now, such as the robotic technology, we can actually really improve our ability to preserve some of those critical male structures and functions. On the forefront of ablation, there's a lot of technology now to ablate prostate cancers. So ablation simply means you're going to apply energy to destroy the tissue, whether it's normal or cancerous. You apply that energy in a very focused, targeted way. So there are a lot of exciting technologies such as high intensity focus ultrasound, laser ablation, and cryotherapy. So that's also being commonly used in treatment of prostate cancer as well. My radiation oncology colleagues have very exciting developments with traditional external beam radiation and also proton beam therapies. And then for advanced prostate cancers, we have exciting new medications that can manage or effectively control the cancers and allow patients to live longer with more advanced cases of prostate cancer.
So we've come a long way. I mean, obviously you're talking futuristic lasers and robots. So obviously the treatment has advanced significantly over the last several years.
Absolutely. It's very exciting, and I think it's a true benefit to patients. And what's really exciting is what the future holds, because all this will only continue to improve and give men more options and better outcomes.
Dr. Pak, anything else that you'd like to add that we haven't addressed?
You raised a lot of important points about prostate cancer, and I just want to make sure that all men listening and all, anybody listening really, if you feel you have a family member or a person you care about at risk, I would highly advise them to get checked at least once a year if they're in those age groups that we talked about there that are at risk, or if they have a strong family history. It's a shame when I meet a man who's never been checked before and presents at a very advanced stage. And I think when you talk to those patients, there's a lot of regret about not doing a simple screening test, because these screening tests we're talking about are very simple. It's a blood test, it's a prostate exam with a finger, and I think they're simple enough and less invasive than some other modalities of screening, such as colonoscopy. I think, frankly, for me, a colonoscopy is a little bit more intimidating than just a finger exam. So, and it's much easier to do a prostate exam with a finger. There's no anesthesia required.
Especially with your hands.
Well, especially with my hands, yes.
Our thanks to Mayo Clinic urologist Dr. Raymond Pak for joining us today to highlight the importance of prostate screening. Thanks for being with us today, Dr. Pak.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on podcasts. Thanks for listening, and be well.